Just as kind of a bit of background to the programme. So Miles Frost died suddenly of cardiomyopathy, hypertrophic cardiomyopathy in July 2015. Young, fit and healthy. He was only 31. Miles Frost's family was devastated. Even more so when they discovered that his father, Sir David Frost, probably had the same condition and he inherited the condition from his father. The family set about raising money to set up the Miles Frost Fund to improve the opportunities and the access to genetic cascade testing. And they raised £1.5 million to do that. And they worked with, in collaboration with the British Heart Foundation to try and use that money to improve services. So with that £1.5 million, we supported 13 sites across the UK in 2 phases to improve the cascade services that were available. Can you see okay? So in 2 phases, first phase was Belfast, Gowston, St Thomas's, Sheffield, West of Scotland. West of Scotland included Dumfries, Galway, Lanarkshire, Glasgow, Ayrshire and Arran, and Forth Valley as well. Oxford and Wales, the Southern Wales ABMU. Don't ask me what ABMU stands for, I can't pronounce it. Phase 2 was in Leeds, Birmingham, Manchester, east of Scotland, which was Grampian, Tayside, and in Lothian, Liverpool, Bristol and Southampton. I have to say that, unfortunately, Phase 2 sites, in terms of the evaluation, especially were impacted by COVID, with many of the staff there being redeployed to COVID-related activities. BHF also commissioned an independent evaluation of the programme, and it's that I'm really going to talk about this afternoon, and that's we interviewed a lot of the stakeholders, a lot of the funded posts, and this is the kind of the results of that evaluation. This programme kind of fitted in well in terms of the sequence of activities that BHF were taking in this area, and that we'd previously done work on genetic cardiac nurses and also FH cascade testing, so there was opportune for us in terms of these 13 sites and the Miles Frost Fund as well. So 13 sites got funding from the programme. The majority of that funding went upon recruiting new staff to implement their delivery models, freeing up time for existing staff and creating new capacity to do so. And also a lot of the sites planned a lot of workforce development activities as part of that as well. So there was fundings of Band 7 nurses, genetic counsellors, but also administrators and coordinator posts as well, which was a key aspect, and I'll come on to again that in later. All sites had previously offered some form of cascade testing, but were using the funding to explore expansion and development of their services and using different service models as well. But the kind of challenges they were facing at that point in terms of the cascade testing, there was a lot of bottlenecks and long waiting times in terms of service delivery. There was inconsistent and less than ideal standard practices for patients, not great processes, inconvenient service arrangements, particularly for the patients, and lack of coordination between some of the services involved as well. And the lack of referrals into the services due to low awareness of the programme, low awareness of the service, and one of the things they wanted to do was improve on that. So a number of the delivery approaches they were considering putting in place, a one-stop shop to kind of get everything done in one single appointment for the patients and the families, using video clinics and mainstreaming for genetic testing, establishing parallel clinics so that they do the cardiology and the genetics together, but also establishing triage processes. But one of the focuses for quite a few of the sites was using a hub and spoke model to try and increase the capacity and increase the access across the areas as well. And that kind of the local centres feeds into that as well. Some pilots were looking at how they could raise awareness of the services across the area and had a number of activities in place to do that, especially within primary care. So I'll just move on to the outcomes, and as I say, this is a result of the interviews that were done with the stakeholders in funded posts. And we did do some work, our evaluators did do some work with patient groups as well, especially during that phase 1. For patients, there was certainly increase of access to the cascade testing and the genetic testing as part of that. Improved access in terms of the outreach and provision through the hub and spoke model, and reduced travel time for the patients, especially if they're having numerous appointments. Reduced waiting times, primarily due to that increased capacity that was provided, but also use of telephone and video clinics, and that was especially relevant during COVID, and I'll come on to that in a second as well. Overall, there was an improved patient experience as a result of this, where the services were much more joined up, the family were more involved, and there was also more time for the patients in terms of the clinical time from the staff and that as well. And there was improved communication and engagement with the families as part of the process due to the funding as well. Wider outcomes for staff and the service. There was increased clinic capacity and there was more staff that were available, and that anecdotally was also improved staff morale. They weren't so harassed, they were able to spend more time with the patients and felt much more relaxed in doing so. There was improved efficiencies in the system, improved attendance rate by the patients, either because they had local services and didn't have so hard to travel, but also using the phone to reduce the number of times they did have to come in. Funding of some of the admin tasks in terms of the admin staff and the coordinator meant that there was much more time for nurses to spend with the patients, and the admin tasks were being done at the right level as well. There was improved coordination and care between the services, and there was improved referral processes as part of the whole process, as part of the implementation. There was improved overall staff knowledge of HCM and cascade services, especially during the hub and spoke, where the wider cardiology teams were more aware of the services that were available to them. Across the regions, there was increased awareness of both ICCs and cascade services for HCM. Lots of GP events were done so that the referrals could be improved. There was improved access of equity of access, primarily due to the hub and spoke model, but also due to the increased capacity available through the process. There was improved relationships between sites, and I can't remember who I was speaking to earlier on, that the number of that we were able to bring people together from all the sites and improve that coordination between sites, and improve that coordination between the funded posts as well. There's closer working relationships. These kind of learn and share events that we did as part of the programme allowed that to happen, allowed if you had out of area people within the cascade testing, you knew who to contact and how to get hold of the local families and local clinicians as well. In terms of what worked well in terms of the programme, these nurse-led clinics that were implemented did work well with appropriate triage and appropriate level of care. There were challenges with that, and I'll come on to that in a second. The coordinators and the admin posts were essential, are quite an asset to the people who had those posts funded in terms of freeing up clinical staff time. Using ICC nurses instead of HCM-specific nurses increased the flexibility within those posts and the capacity within the overall service as well. The use of telephone reviews, especially during COVID, was a tremendous asset as well, and improved the service for the patients as well. The opportunities for training and shadowing, especially shadowing for training for new nurses coming into the service, being able to shadow their more experienced peers was a great opportunity as well. And some of the spokes had champions in place where they could raise the profile of the spoke, but still have the clinical expertise available to them from the hub. The challenges that were expressed by the sites, these new nurses, funded nurses, needed significant support to get to the point where they could run the clinics on their own and run them independently. There was a lack of competencies framework at the very beginning of the programme to allow that to happen and to support them in that process. A lot of the sites had significant challenges recruiting to all these posts, especially the more specific posts like genetic counsellors. There was at least one site that took a year and a half to recruit to that post especially. Finding appropriate candidates was quite a challenge. Having that hub and spoke model, although it worked well in providing access for the patients, it did prove problematic in providing training opportunities for the staff involved, where you then had kind of separated experienced and new staff as part of that model. So that would need sites needed to think more innovatively about how they did that training process and how they supported the people in the hub. General new service setup, clinical setup, obtaining clinical space and resources was always going to be a problem. Funding, we were funding sites initially for 2 years, and we were asking sites to provide match funding in part of that second year. And a lot of sites found that quite challenging to get that sustainability funding in place and getting funding from elsewhere, and then think about that sustainability after that 2 years. And overall, a lack of a national database to which record these cases, although was identified as a challenge, was completely out with the remit of this programme as well. I'm sure that'll probably come up at some point today as well. General challenges in terms of the delivery of the service, staff absence and leave. As a clinical administration, where sites hadn't got administrative funding, and that was a big challenge for them. The hub and spoke models were, as I say, a great asset for the patients, but were really difficult to set up because of the different processes, different IT systems between the hub and the spoke, and getting that to work effectively. And keeping up with the demand was also a challenge as well. Everybody was raising awareness of the programme, but that meant more referrals. But I think you have to have that balance. And there were still bottlenecks in place, even at the end of the programme, in terms of waiting times for clinical tests. As I said earlier on, phase 2 sites were significantly impacted by COVID, with some folks being redeployed to cover COVID-related work. BHF continued to fund those posts during these periods. In terms of cascade testing, there was a reduction in service capacity. There was no or limited face-to-face appointments going on during that period, so therefore it resulted in a backlog of patients and increased waiting times. But it did kind of accelerate one of the changes that a lot of the sites were considering at that point in terms of use of telephone and video appointments to support those patients during that period as well. Some of the key learning that came out from these interviews, that it was important for the nurses who were employed to have significant experience of cardiology, but also have a sport environment to learn that genetics expertise that was part of this post as well. There was a needed for a substantial lead-in time to a point where they could run their own clinics as well as independently, as I suggested earlier on, but also have one of the key learnings was to have key relationships between the clinicians in the hub and spoke, so that there was a good communication and good patient management between the two sites as well. As I said earlier on, the administrator role was an asset to those who had it funded, but also using the kind of optimising service design to make sure that when you're scheduling and appointments on the same day, and kind of having that infrastructure in place to enable the efficiencies, that was a key aspect that needed to be very well planned out. And that last one is a bit of a balance there. The increasing awareness of genetic testing increases the workload, but we were providing capacity in order to do that, but it continues to need to be a bit of a balance going forward. And just finally, this was from the evaluators, the key things that needed to be in place for developing an effective HCM service, supporting the specialist nurses to lead, giving them the opportunities for training and development, especially with genetic, if they're supporting them with the genetic counselling. Having that support in place, either allowing the specialist nurses to do that genetic counselling as part of their role, or having those parallel clinics, so that there was engaging with the wider genetic services, and finally just establishing that good infrastructure to support those services, including SOPs and templates and so forth. Thanks very much.
Thank you, Iain. It's great to hear about some of the successes of the programme, but in the interest of time, I think we need to move straight on, but I'm sure people can grab you at the end of the session if they've got any particular questions. So next, I'd like to invite up, hello, I'm glad you're here, Dr. William Bradlow, who's consultant cardiologist from Birmingham, did some research in cardiovascular magnetic resonance at the Royal Brompton, I believe, and completed your training in Oxford, and are currently clinical lead for services in Birmingham. Thank you. Okay, 5. 2. There's a countdown going on upstairs.
Am I being invited to find it? Okay.
Oh, stop. He's saying stop. Are you touching? Stop whatever you're doing.
If it's easier, should we switch and I can...
Yeah. Shall we switch? People upstairs in charge? No. They're saying no. Yeah, any questions for Iain?
Question for you, if that's okay.
Yes, that'd be.
Iain, I work in Leeds. I'm a university council part of the project. Is the report going to be? Oh, I think I can share enough. Is the report going to be available to those centres that took part in, in the BHF Miles Frost project? Because that's really such important information that's come out of that. That I think, as our managers would and clinical lead would be very. It's important they know about what the project brought and what the recommendations are.
Yes, is the answer. We're just going through final sign-off within BHF, and there's going to be a phase 2 report. And the phase 1 report's already on the website. Phase 2 report will be up there soon, along with a summary of both phase 1 and phase 2.
Great, thank you. Thanks very much.
Right, thank you. I think we can move back to
Brilliant.
you.
Thank you very much.
Sorry about
and
that.
Also, thanks very much for the invitation to talk. So I'm going to be talking about applying population health to inherited cardiac conditions. Those are my disclosures. I think it's fair to say that things aren't great at the moment. As there's an array of these acute crises, which I've borrowed a term from economic circles called polycrisis, where you've got these number of independent but related issues arising all at the same time. And the burger was a reminder to myself to say, as well as all these acute crises, we've got patients coming through with lifestyle-related comorbidities. And in fact, this burger is produced by a West Midlands branch, or they're called Burger and Sauce, and their first store was in Alum Rock, which is one of the most deprived wards in Birmingham, and they are a pandemic winner because last year they made 2 million in revenue. So we've got problems, and at the same time, I think as Stephen really nicely articulated, at an ICC service level, you've got some really big challenges. You've got more patients being referred, you've got therefore more people being referred for screening. And that assessment in clinic is now more complex because of mainstreaming, genomics, and also all the risk stratification that's been described. And at the same time as all this is happening, we're also preparing the ground for a whole tranche of new medications. And so the question is, how do you address these multiple challenges simultaneously? You need something that isn't dealing in silos, in isolation with one problem and another. You need to think more systematically. And that's where population health offers promise in addressing these issues. So in terms of definitions, population health, you can read there, is health outcomes of a group of individuals in a specified population, including the distribution of such outcomes within the group. And population health improvement, I'll let you read it, but I've just highlighted some keywords there. So it's about systematic efforts, it's about measurable improvement of health outcomes, and it's got to be co-produced with and for the population in their locality. And although this has been traditionally applied in primary care, what we're thinking about here is our population of ICC patients, initially by institution, but you can think more broadly than that. So what does it help to achieve in primary care circles? It's a very good way of understanding the work you've done and the work that needs to be done. It also gets away from this episodic instances of care to one where you can be much more proactive and have impact at scale in a very short period of time. It targets sub-cohorts of the population who are at particularly high risk, and hopefully, in the end, you'll be able to show that you've used resources more wisely. So what might this look like in an ICC cohort? So here's our Birmingham population, which through the specialist service, this is registry data, and the eagle-eyed amongst you will see it only covers 60% of the population, and essentially our echocardiographer got too busy to complete the data in the registry, so we're missing 40%, but that gives you an idea of the challenges associated with this type of work. But nonetheless, there's some really useful, there's some really useful learning. I mean, the first thing is you get a sense of just how much work you need to do to identify the high and intermediate risk patients versus the bulk who are low risk. The second advantage is that you can start to think about whether these people need as frequent follow-up as those who are more predisposed to complications. So that's at a service level, but population health teaches us to think beyond the walls of the clinic. And if we take a step out, we can think about those people who are looked after in the hospital but aren't necessarily seen in the service. And that's represented by this sort of triangle of the population there. And so we did a piece of work where we aimed to define the cohort of patients in one hospital using a combination of techniques from registry data, coded data, but also text mining, which is essentially speed reading at scale of clinical records, so clinical documentation. And I anticipated that we would be seeing all of the patients with hypertrophic cardiomyopathy because that's what the guidelines recommend. But in actual fact, the truth was quite different. So here's our specialist service here. We've got a reasonable number with HOCM, and then we looked specifically using text mining for instances of AF and heart failure and found an additional number. We found people who'd been lost to follow-up. But importantly, in the non-specialist, these are patients managed outside the specialist service, and you can see there's a very large number. And they don't all have straightforward disease. If we take that a step further and think about undiagnosed patients, then it brings us to screening. Now, we haven't yet done the work internally to see what our outcomes are from screening, but plan to. But this is a visual summary of the paper that from the Bart's team, where they looked at 15-year outcomes for patients who were initially phenotype negative, but who were genotype positive. And you can see, very similar to the first chart I showed, there's a sizable amount who have HOCM, a number who develop complications. But again, you've got this target of people who are continue to be phenotype negative, who you could then target to reduce the interval of follow-up or maybe discharge altogether. Now, local data on our percent of probands who are going to be pathogenic or had a likely pathogenic mutation was really instructive, because it was a lot lower than both the share registry or HCMR data would indicate. And that was really important because essentially it was telling us that we were going to be driving a lot of people towards clinical screening. And that shaped our thinking about how we would deliver that kind of service in the future and encouraged us to move towards a sort of virtual screening model. So understanding your local population is really key. A second aspect of population health is make equity a property of the system. So this is data that really has only come about in the last 5 years, but we're already starting to see that there are important differences in outcomes and access to services for people of different genders and ethnicities. And in this work here, again from the Share Registry, they showed if you were Black American, you were less likely to be gene tested and less likely to have invasal septal reduction therapies. And similarly, this paper from the Portuguese registry showed that if you were in a non-specialist centre, you were less likely to have access to genetic testing. So there are important aspects around equity of access to certain diagnostic procedures or treatments that we need to consider when thinking about our ICC services. The third thing one needs to think about is partnering with those with lived experiences. And I'm always struck going on holiday to various parts of the UK that there's always a BHF store on the high street, and it's like the most visible aspect of this amazing network present nationally. And the same is true for lots of the other charities who are affiliated and operating in this space. So we've got this amazing patient resource, and lots of people obviously are using patients all the time when developing their research projects. But the same thing would apply to thinking about how we deliver population health at scale. Fourthly, we need to gather meaningful data more often. And this is an excerpt from a discussion about how Uber became really successful. And one of the things they did was to give each team a vision of what they were achieving locally. And that really sort of excited me, because as you can read here, it got them to see how well they were doing compared to other places. And it's sort of striking that that's actually really difficult to do in any subspecialty in cardiology, because we just don't have that data. But dashboards, and they have to be sort of contemporary dashboards, we really don't want something that's only giving you information every year, are really important. And this is just something that we've moved our registry to very recently, but it gives a sense of what's possible. So we've got an age and gender distribution, most of our patients, as you'd expect, from West Midlands, and then you've got a map of where they are. And then you can take a step further to think about where are your patients from, and who are the patients who live in areas of social deprivation, and does that potentially have an impact on their outcomes, and can you do anything to modify that situation? And I'll just let this run. So this is just showing that you can then drill down onto populations of interest. So this, for example, is really helpful when we're starting to think about which community clinics would be potentially suitable sites for delivering screening services. And then the fifth recommendation, and I should have mentioned it earlier, these 5 steps are described by Ninon Lewis, who's very involved in population health at the Institute for Health Improvement in the US. The fifth part is thinking at scale. And so you can think at a very local level, in your ICS level, then you can think about a regional level, and then you can think at a national level. And the points I wanted to make here was that, you know, the door is half open for all of this work. ICSs are built on the idea of population health. So it wouldn't take really that much for ICC to establish itself within ICSs and then build on all of the already existing infrastructure. And I was really excited by what Steve said at the beginning, that actually it's the AICC's vision to start to integrate this and coordinate data and centres in a much more joined up way to try and take advantage of all this, of all the things that I've described. So in conclusion, public health improvement could help to address the multiple challenges we're all facing as a community. There are 5 key steps to develop a foundation for this type of work, and I think it's fair to say that all of those are achievable, and much of it's already in place. It just needs pulling together. And if I just take forward this idea about being competitive within cardiology against other subspecialties, I think we do have a really good opportunity to leapfrog what other specialties are doing and be forerunners in this area. Thanks very much.
Thank you, William. I'm sorry about the technical issues.
No
and I think it's it's definitely a key priority for genomics strategy is this equity of access. So good reflections for us to go away and think about. Thank you.
Great.
So I'm just going to move on swiftly. And we have a second appearance from Joe Westaby. Joe's a clinical lecturer in histopathology at St George's and did his PhD and clinical fellowship with CRY, and you're going to talk about sudden cardiac death.
Thank you very much for inviting me to speak today. I'll just put that slightly up. Can you hear me? So I've been asked to speak about sudden death and left ventricular hypertrophy. I'm going to give you the pathologist's view on it, and I'm going to run through some of the different... First of all, I think it's going to be important to define what I'm talking about, talk about our pathway, so how we receive our referrals, then speak about how we assess the different cases, and then what the proportions are in our database. So I'll start off with the definitions. I think sudden death is obviously important to define, and we're talking about people that die within 1 hour if they're being witnessed, or 24 hours if that's unwitnessed. Left ventricular hypertrophy. Now, I think for a pathologist, this is actually quite a different entity compared to what you diagnose clinically. We don't look for 15 millimetres wall thickness, which is unexplained by loading conditions. For us to look for left ventricular hypertrophy, we're actually looking at the heart weight. And the reason that I say this, so this is a nice image of a hypertrophied left ventricle there. The reason that I say this is because we get samples like this, and this is what we refer to as death in systole. So it's a hypercontracted heart, and what you can see here is that you've got a thick wall. This is well above 15 millimetres, but actually the cavity has been obliterated, so this will be a normal heart weight, and that's why we don't use the wall thickness, because we get at least about 15% of our cases are what we refer to as death in systole like that. So moving on from there. Okay, so we've spoken about left ventricular hypertrophy and the fact that it's got an adverse prognostic factor. It's about 6 to 8 times more common sudden cardiac death in individuals with left ventricular hypertrophy than the normal population, and 2 to 3 times in females. It's associated with a much higher mortality over 12 years, and hypertrophy is sort of as a substrate for arrhythmia and also sudden cardiac death. So moving on to our pathway, this was meant to come up in the individual bits, but it doesn't seem to have. So individuals will pass away suddenly, undergoing sudden cardiac death, and then they'll have an initial autopsy. And what is now happening is we used to have a bit of spleen genetic material coming along with the heart, but that's now being sent separately to the genetic hubs for genetic testing, and we're receiving the heart as expert cardiovascular pathologists, and what we'll do is we analyse this macroscopically on the bench and look for any anatomical changes that we can see, and then the other part of our examination is taking histology, so we look at the tissue underneath the microscope as well, and here you can see fat and fibrosis infiltrating into the myocardium. So these are the myocytes here. That's the fat, the clear area, and that pink material is the fibrosis. And then we're hopefully going to combine all these results in future, and then in cases where we think there may be genetic etiology, we'll advise that the family is screened by cardiologists. Right, So moving on to speak about the pathological assessment. Now, there have been guidelines published by the AICC, which illustrate this beautifully, but I've chosen to illustrate it with a number of cases that I've seen over the last year. There is also UK national guidelines. They don't give many specifics, but they certainly illustrate exactly what we're looking for in those papers. Now, one of the things that we get through with our referrals of the heart are normally a history or the circumstances of death. Hopefully we'll get a past medical history. We sometimes also get a family questionnaire as well. So the important things in cases where they've got left ventricular hypertrophy are looking for things like hypertension, obesity, diabetes, but we've certainly mentioned about a number of phenocopies and such as muscular dystrophy that may muddy the water and neuromuscular disorders. And I'm going to talk a little bit about how they where we would see them in some of these cases as well. So one of the first things that we can see on the bench, this is a mid-ventricular slice. So we're looking upwards into the heart, and you can see the mitral valve there. So we can either look to see whether it's symmetrical or asymmetrical. So this points us towards different causes depending on that. So on this case, we can see a little bit of fibrosis up there. But it points us towards something more like hypertrophic cardiomyopathy, whereas this would be more in keeping with obesity or hypertension, or we'll come on to other conditions that may underlie that as well. But that's something that we certainly look for. We don't tend to talk too much about dilation of the cavity because it is something that can happen. Certainly, the longer time that the individual has been before the heart's fixed post-mortem, as it degrades, it tends to dilate more, and we can also see that the wall thins as well. So that makes our analysis more tricky in the post-mortem setting when we're looking for dilation. But here is a nice case where we've got a very enlarged left ventricle here, and you can see a very enlarged right ventricle here. So this is a classic case of dilated cardiomyopathy, but this is something that can be very tricky for us as pathologists to diagnose. And we have a number of cases, some which actually, when we look at them macroscopically, they don't have any dilation of the cavity and the walls are of a normal size as well. And when we look down the microscope, we don't even see any fibrosis as well. So it can be very tricky for us to diagnose dilated cardiomyopathy in the absence of there being a clinical diagnosis. Other things that we can look for is this impact lesion. So you can see the mitral valve, which lies here, which we've incised up, and this is the left ventricular outflow tract, and then you can see the aortic valve at the top, and here's the membranous septum there. And what you can see here is essentially what we refer to as an impact lesion, and this is where the mitral valve, the anterior leaflet, is thought to impact against the septum during the systolic anterior movement that you see. And that's something that we can see characteristically in HCM, but we also see some of these changes in phenocopies, such as amyloid, which has been mentioned today, but we can also see it in elderly female patients as well. So it's important to consider other conditions, and we don't make a diagnosis of things like hypertrophic cardiomyopathy until we've got our entire analysis, both our macroscopic and microscopic. So other things that we look for within left ventricular hypertrophy are other explanatory factors, such as this is a case where you can see that the aortic valve is markedly abnormal. You can see that they're thickened and there's some nodularity to the valve as well. So this is a heavily calcified aortic stenosis that would explain the left ventricular hypertrophy. And on the right here, we've got a case where you can see this white discoloration around the anterior of the heart. So you would see the LAD down here. This is the anterior septum. And then you've got the anterior wall there. So there's fibrosis in that area. And then when we examine the coronary arteries, you can see that the left anterior descending was completely occluded by atheroma in this case. And we would have diagnosed this as a chronic ischemic heart disease. So moving on to microscopic analysis, this is some of the changes that we can see when we're looking for genetic causes down the microscope in left ventricular hypertrophy. So this is the classic myocyte disarray. I've mentioned amyloid as a phenocopy. So as I've said, it can mimic hypertrophic cardiomyopathy, both macroscopically with that septoid the abnormal septum with the impact lesion, the asymmetric hypertrophy, but it can also, the thing about amyloid is it looks what we refer to as an amorphic eosinophilic deposition within the heart, which again, fibrosis it's pink and it looks quite similar to amyloid. So it's something that can trip you up. And the other thing it does do is when you get amyloid deposition in the heart, it can also lead to this myocyte disarray. So I find it very useful to look at the vessels because you'll see amyloid deposition in the vessels and that enables you to identify it. But it's something that can trip you up when you're looking and trying to make a diagnosis of hypertrophic cardiomyopathy. Here on the right, we've got a picra serous red stain. So the red is staining the fibrosis, the yellow is the myocytes, and the white is the fat. So you've guessed it, there's fat and fibrosis. It's an arrhythmogenic cardiomyopathy, which is very useful within these cases. So the other thing that we can look at, where we don't have any of these factors that obviously label it as an inherited condition, are the distribution of the fibrosis and what the fibrosis looks like. So here we've got patchy, what we call replacement fibrosis, but you can see it kind of intermingles maybe with some interstitial, so that interstitial moves between the myocytes like this. So this can be more of a feature with ischemic heart disease, but also hypertrophic cardiomyopathy. And then the interstitial fibrosis we tend to see more in things like dilated cardiomyopathy. It can also coexist in hypertrophic cardiomyopathy as well. And we also see it within hypertensive heart disease. So those are all factors that we look for when we're making our assessment, both macroscopically and microscopically. So our database runs from 1994 to 2022. So this has been updated relatively recently. You can see here on the right, this is our referral numbers. So in 2013, we had 310 cases with only 21 spleens. But you can see that the number of spleens which enable us to do the genetic analysis have been increasing, and our referrals are here as well. And we've now got a total of nearly 7,700 cases in our database. And I've reviewed the whole database and I found that there was 1,307 cases with left ventricular hypertrophy, representing 17% of our cases. And these are the proportions, which you can see here. So you can see that idiopathic left ventricular hypertrophy, which I'm going to come on to in a minute, made up 21%, so that was our most common. Obesity cardiomyopathy, which I spoke about earlier, made up 14% of our cases. Ischemic heart disease, and we acknowledge that we don't receive all the ischemic heart disease. That's generally diagnosed by the initial autopsy practitioner. These are also predominantly young, I should say. So ischemic makes up 12% in our series. Hypertrophic cardiomyopathy was 11%. Others, including amyloid and some of the phenocopies that we've mentioned today, made up 9%. Hypertension, 9%. And this may also be being diagnosed by the initial autopsy practitioners and may be more common within the UK itself. Then valvular disease made up 7%. Congenital heart disease made up 7%. And I suppose I should acknowledge that some of these may have right ventricular hypertrophy instead of left ventricular hypertrophy when you're looking at it with regards to what's accounting for the weight. So, for instance, just to say that I had a case of transposition of the greater arteries where they'd done the Muster procedure, and obviously there was massive right ventricular hypertrophy in that case. But otherwise, most of the cases will be definitely left ventricular hypertrophy. Dilated cardiomyopathy made up 6%, and then arrhythmogenic made up 4%. So you do see increased heart rate with ACM, but it's in a smaller proportion than what we see in the rest of our population. So those are just highlighting the well-recognised genetic causes. And now I'm going to move on to speak about idiopathic left ventricular hypertrophy. So this is a paper published first also with Gerardo, with Professor Shepherd and Professor Sanjay Sharma. This is where there was no cause identified for the left ventricular hypertrophy. And in our case, what we're looking for is myocyte disarray. So they're allowed to have fibrosis, but there's no myocyte disarray when we're looking at these cases. And this was regarding 46 cases of this condition. And they were followed up in the family, and it also had molecular autopsy. So on the molecular autopsy, there were some long QT syndrome was identified in a number of individuals. There was one Danon cardiomyopathy, and then we can see in 30% of the families, there was Brugada syndrome identified as the most common within the families, 3 long QT syndromes, 1 Wolff-Parkinson-White, 1 dilated cardiomyopathy, and 1 arrhythmogenic cardiomyopathy. But what stands out from this data is that there is no sarcomeric HCM, so there's no hypertrophic cardiomyopathy genes found in any of these patients with this idiopathic left ventricular hypertrophy. So on that basis, that we concluded that this is a distinct condition from hypertrophic cardiomyopathy, and that it's associated with more arrhythmia syndromes rather than being hypertrophic cardiomyopathy. So just to finish off, I'm going to quickly show you some pictures of hypertrophic cardiomyopathy and show you how it is distinct. So again, we've got this asymmetric left ventricular hypertrophy. You can see the impact lesion here, and this is the thickened mitral valve, the anterior leaflet of the mitral valve, where it impacts against the septum and causes this fibrotic lesion on the surface there. And then this is the myocyte disarray. And I want to highlight that this is the important thing for us. So hypertrophic cardiomyopathy, rather than being greater than 15 millimeters of wall thickness, unexplained by loading conditions, for us is diagnosed on the basis of myocyte disarray. So we're wanting to see this present in 20% of 2 of the tissue blocks that we take, and that's how we make a diagnosis. So whilst we are looking for an increase in heart rate, about 12% of our cases have a normal heart rate. We do also look for the left ventricular hypertrophy, but this is not necessary for us to make the diagnosis. We see this thickening of the anterior leaflet. Again, this is not necessary. We see the impact lesion. We'll see fibrosis. It tends to be patchy. You get patchy replacement fibrosis. It tends to be kind of randomly distributed throughout the myocardium in comparison to sort of other conditions where, like in arrhythmogenic cardiomyopathy, it's definitely epicardial based. We do get myocyte hypertrophy, but again, it's generally there. But myocyte disarray is the main thing that we're looking for. That's our diagnostic feature in HCM. Okay, so I hope I've run through the definitions of what we do, run through the pathway, the assessment, and the proportions in our database. I just want to acknowledge our lab. They do a great job, and I should say that we're sponsored by Cardiac Risk in the Young. Thank you very much.
Thank you, Joseph. That's great data and wonderful interviews.
Thank you.
So we're going to move on very rapidly to this London time as well, to our final speaker in this session, and that's Dr. Simon Hobson. He's a cardiology specialist registrar. And can you talk to us about heart failure?
Yep, that's right. Afternoon, everybody. So I lost my voice at the weekend, so it's just started coming back today. So hopefully you can hear me okay. So I'd like to thank everybody for inviting me to present my abstract, which is entitled Yield to Genetic Testing in a National Heart Transplant Programme. I'm one of the registrars here in the west of Scotland. And the background to this presentation really is that, as you may know, the cardiac transplantation is a treatment reserved for the most advanced forms of heart failure. In the modern era, the commonest indication for transplant is non-ischemic cardiomyopathy, of which dilated cardiomyopathy is the commonest phenotype. Like we've seen today in a number of the presentations, dilated cardiomyopathy is classified as idiopathic in the sort of majority of cases. And that's sort of something that's not really ever, sat well with me. And I worked a couple of years ago in the transplant. Oh, I've got a bottle here, but I don't think it'll make any difference, to be honest. I'll take a swig. So a couple of years ago, I worked in the National Transplant Unit based here in Glasgow, and that sort of led to this project because we were seeing lots of patients who were presenting with advanced disease, often as a de novo presentation, often young patients, and didn't always have a family history of disease. So Given that, we had a hypothesis that advanced heart failure amongst this population would be likely to have a substantial genetic basis. So this was a single centre study based here in Glasgow, which is the National Heart Failure Centre, Advanced Heart Failure Centre for Scotland. It was a retrospective analysis where we looked back at patients since the beginning of the service, which was in 1992. And the main questions we wanted to answer were, what was the etiology amongst our heart transplant recipients? How many of them had genetic testing? And then amongst our patients with genetic testing, what was the yield? So as I mentioned, the National Centre is based here in Glasgow. It serves a population of 5.4 million. It's one of 6 transplant centres for adults in the UK. And the first transplant was on the 2nd of January 1992. So they celebrated their 30th year anniversary this year. So that seemed like quite a nice time frame to choose. So we collected data for the patients who were transplanted over those 30 years. Used paper and electronic records as well as genetic lab results. And we recorded a number of factors, including the date of transplant, when they had genetic testing, as well as the etiology of their cardiomyopathy. And particularly, we focused on non-ischemic cardiomyopathy and looked at the patient's diagnosis pre-transplant as well as their tissue diagnosis following their transplant. So as a rough summary, there was 423 transplants in those 30 years. 75% were male with a median age of 50 years. And consistent with sort of international data, the majority of patients had non-ischemic cardiomyopathy. But looking over the 30-year period, there was a trend across that. So initially, on the left-hand side here, in the 90s, there was a greater proportion of patients with ischemic cardiomyopathy, and that sort of fell away really in the sort of corresponding with a number of factors, but the emergence of sort of primary PCI and revascularization. And then in more recent years, the trend has been to greater and greater numbers of patients with non-ischemic cardiomyopathy. So we looked at the 242 patients who had non-ischemic cardiomyopathy and the ones who we felt had likely to have a genetic etiology. And as I said, dilated cardiomyopathy was by far the most prevalent phenotype, making up 183 out of the 242 patients. But there was other common causes, including hypertrophic, arrhythmogenic, etc., etc. So we looked at the non-ischemic patients and how many of them underwent genetic testing, and that made up about 34% of the patients over the 30-year period. And then looked at the yield amongst those patients, and the yield of positive genetic testing was about 61%. So we broke that down into the common subtypes, and particularly focused on dilated cardiomyopathy being the most prevalent. And across all the subtypes, there was a yield of greater than 50% for genetic testing amongst this population, with 52% in the dilated cardiomyopathy subtype, but up to sort of 100% in the arrhythmogenic and the left ventricular non-compaction. We looked a little bit more closely then, so 52% amongst the DCM population is greater than typical cohorts in ICC clinics, which is around 20 to 30%. Sorry, it's disappeared from my screen. And amongst those patients who had positive genetic testing, the sarcomeric variants were the most common, with MYH7 being the most common variant that we saw. And we also have ongoing work looking at gene testing amongst family members of these patients. So to date, 112 relatives have been tested, and there's been just over 40% yield amongst those patients. So again, very significant in comparison to the typical numbers you would see in an ICC clinic. Of course, there's obviously a number of limitations within this study. So obviously this is a very select group of patients, who are typically young with very few comorbidities, with a very advanced phenotype. And also then, as this was a retrospective study, obviously patients who had a family history of cardiomyopathy would have been selected to have testing, maybe more so than others. And also the genetic testing has really only been available on a more larger scale in Scotland since 2008. So the majority of patients who underwent testing has been since that time. So there's sort of a number of conclusions really from this, but I think it's clear from this data that amongst this group of patients with advanced heart failure, there's a significant yield for testing amongst those with non-ischemic cardiomyopathy. Clearly this has important implications both for the patients, but as we've heard from a number of other speakers today, there's important implications for family members and for cascade testing. Typically amongst this population, the yield has been higher than that in your typical ICC cohorts. So I'd like to thank you for the opportunity to present, as well as thanking the co-authors, in particular Fiona Henderson, Ruth McGowan and Caroline Coates, for giving me a lot of guidance when completing this. Thank you.
Thank you so much, Simon. I've just been informed that our keynote speaker is running late, so we actually do have time for discussion. So if anyone's 5 minutes. So if anyone's got any questions for this session, for any of the speakers, would the speakers like to come up to the table? Up to the front, there might be some questions for you. Yeah. So, I'm going up here. Oh, you've got it.
They were really interesting talks. Thank you very much indeed. I'd like to ask the last speaker, particularly about the study that you've done from the transplantation cohort of patients. One of the things that we do now is when we're reviewing families is that if we've done genetic testing a number of years ago, we're going back to those families to offer an extended gene panel. And I'm just interested to know, did you just look at the analysis of the data that you had, or was there any revisiting of these families to offer a more extended panel on stored DNA from those patients?
So yes, I think there has been testing which has gone back and revisited. As I say, the genetic service was established in 2008, so some of the patients who had been transplanted prior to that, have had subsequent testing performed. And then there's also been some patients where, as gene panels have expanded, they've gone back and retested again on stored samples.
And of those, were some of those ones where you actually subsequently identified a gene mutation in that patient?
I can't remember numbers off the top of my head, but there has been patients, yes, pre-2008, where they've subsequently tested positive for a genetic cardiomyopathy.
Thank you.
I have a question for Dr. Westaby. So you mentioned in your introduction that the risk of sudden death in LVH patients is much higher in men as compared to women. And I'm curious to know what's known about that. And my second question would be, did you see any differences? Did you break down your data on male-female differences? So did you see a difference in pattern between the underlying pathology, for instance, more obesity in certain gender or something like that?
Excellent question. I didn't present any data on that now, but I can say from our cohort, pretty much most conditions are almost 2-to-1 with regards to the amount of sudden cardiac death with regards to males to females. So that exists within sudden arrhythmic death syndrome, which is our most common hypertrophic cardiomyopathy. I think all the cardiomyopathies, hypertension, so hypertensive heart disease was more balanced between the two, but it's predominantly men that we see within our cohort. that pretty much stands up across most of the different conditions that we diagnose, and that's the same within ischemic heart diseases as well.
Yeah, fantastic talks. Thank you all. A question for Will. So, population health is great. You get granular detail. You find out where there's inequalities. But then, what do you do with it? Because I think there's lots about finding the inequalities, but most people can't then come up with a system to improve it over a period of time. So, what's the next step?
It's a very good question. I mean, at the moment, the steps we've taken so far are purely based on our own service. So, for example, we've looked at people with AF who, for whatever reason, aren't on treatment. We've looked at our LVOT obstruction cohort. But the next steps will be doing exactly as you suggest. And to be honest, I think there's enough expertise in primary care and within the ICSs to piggyback on top of those existing structures and exploit their expertise to find out how best to target and then address those inequalities. I mean, locally there's a huge amount of interest in local community diagnostics hubs, sort of delivering investigations in somebody's own locality, and I think if we can find a way to drive investigations through those hubs, we'll increase the amount of uptake we get for testing as compared to inviting somebody into hospital. Beyond that, I don't have any good ideas, but maybe it's watch this space and come back to it and talk amongst ourselves, because I think we're such a big network that there'll be people who've got success stories in this regard and could share for others to learn.
Question for Joe. Currently, post-SCD testing the English test directory would be driven by the phenotype. So if there's HCM, you only test for HCM. With your comments about idiopathic LVH, with your comments about idiopathic LVH, would you advocate that, or would you advocate a broader molecular autopsy for all?
I think absolutely I'd advocate a broader molecular autopsy for all the different conditions, including the primary arrhythmia disorders, because that's what was predominantly found within the relatives and the also within molecular autopsy. But I think that the thing is to say that it seems like it's distinct from hypertrophic cardiomyopathy. So, yeah.
I've just got a question for you, Joe. So we're really grateful to you and Mary Shepherd's team for performing second look post-mortems from some of our sudden death cases. And I was just wondering if you knew, having a kind of retrospective of the cases over time, if you're seeing less disparity in the initial diagnosis made by the local pathologist and the conclusions drawn by your team as there's increased knowledge of ICCs in the broader pathology community, and if you think that in time there'll be enough education in those groups that the second look will be less important. I just wonder what your view is on that.
Excellent question. I haven't necessarily reviewed kind of more the historic cases with regards to the disparity in diagnosis. I can tell you about sort of current trends. I think one of the things which has been highlighted to me by actually a number of cardiologists has been about the diagnosis of arrhythmogenic cardiomyopathy with just fat infiltrating into the heart, which is, I always try and get across, is an entirely normal feature. I've just published a paper on the normal heart, and you see it, across the board. You'll see it in almost every individual. Even transmural fat infiltration is something that we do see in the normal heart. It tends to be more seen in obese individuals and elderly females. But with regards to other ones, we are still seeing a disparity in diagnosis. I think absolutely education will help. I think when we're going to specifically narrow down the targeting for screening, both genetics and within the family, I think it's important that we get a second diagnosis, and that would be whether it's me making the diagnosis or whether it's someone else making the diagnosis. I think if we're doing a broad screening and we're going to look at everything, then it's probably, it's more acceptable maybe that diagnosis is made. elsewhere. But I do think it's important that we make sure that we're getting the diagnosis right. And I think that there's still variability. The guidelines don't necessarily yet have strict cut-offs for all the diagnoses that are made. So it is to necessarily pathology is still a subjective specialty. We're analysing images down the microscope, and quantification and stuff. I think that'll be the way forward. Certainly, the incorporation of AI into the analysis of pathology may help as well with regards to that.
Great, thank you very much.
Well, I had a question, but you answered half of it. There were two of them. One question was how important you think, or how valuable you think would be to network centres and share the anxiety, the expertise, and review the cases together, given, as you said, that it's a subjective to some extent diagnosis, and the expertise is limited. We cannot clone you, cannot clone Mary. It's difficult to do this in the whole country. And the second question was about AI. If it is subjective, then I would assume that AI may not be as useful here. If we can, or you can possibly make it more objective, then I'm sure there is room for AI and for a machine to give us a diagnosis after we teach the machine.
Absolutely. I think we're certainly moving towards digital pathology, and the sharing of images is becoming much easier than it has been historically. Hopefully we're going to be scanning in all our slides within the sort of next 5 to 10 years, and that should really enable us to share images far more readily than we are. I'm not aware of anyone routinely scanning in all their slides with regards to at least post-mortem work. It has started to be incorporated. So digital pathology is a big movement within the NHS with regards to sort of cancer diagnosis, but it hasn't quite come into post-mortem work at all. The funding is obviously much more limited in that. But also with regards to AI, yes, absolutely. I think myocyte disarray is very difficult to quantify. It's normal in some areas in the heart. If you could get a machine to learn how to analyse the sections and quantify it for you, and then you could review those cases, I think it will require an operator there or someone to oversee it as well when we start incorporating AI into the analysis of the slides and the different conditions and stuff. I think it will certainly be an interesting time, but I think it would be of assistance in at least screening, and then you need to get a pathologist to review it with expertise as well.
Fantastic. It was great to have that extra opportunity that we weren't expecting to ask those questions, and thank you to all the speakers for a wonderful session. I'm now passing over to Dr. Iain Findlay to introduce our keynote speaker.
Who doesn't know how to make this work? Oh, is it working? Yes? Yes, great, okay. It is my great pleasure to introduce Professor Dame Anna Dominiczak. Anna and I, if maybe so informal, go back quite a few years. We were both junior doctors in the Western Infirmary and at the August Institution of the Royal Alexandra Hospital in Paisley. And whereas I went on to become a consultant there, I think it's fair to say our paths diverged somewhat, certainly academically. And Dame Anna is now the Chief Scientist for Health for the Scottish Government and Regius Professor of Medicine at the University of Glasgow, and has rightly been recognised with an OBE and DBE for her services to medicine. I think it's fair to say that she's one of Scotland's few world-class scientists, and particularly with her interest in hypertension. And I well remember, I'm going to say she's quite a formidable person. When I was on the hospital formulary, we had decided not to put amlodipine on because it was more expensive than nifedipine. And Anna was on the MRC hypertension unit, and I received a phone call. Iain, Anna here. Next year, amlodipine was on the hospital formulary. Some of you here may well work at the Queen Elizabeth. Now, I was on the area medical committee when this was set up, and the plans included a leaky roof and faulty cladding. But what it didn't include was a medical school. It was an £850 million hospital. It was going to be the biggest hospital in Scotland, and there was absolutely no provision for a medical school. And Bob Calderwood at that time was adamant that this project was coming on budget. And it was Anna who was then, at that time you were, basically head of medical sciences at the University of Glasgow, and it was through her drive, her resource research for funding, etc., that we have got a world-class medical school on that facility. She's got a host of titles which I'm not going to go through. I think for us, though, one thing we do owe her a debt of gratitude is that in 2020, Professor Damana successfully led the establishment of a Lighthouse laboratory in Glasgow to provide rapid COVID-19 testing, and then went on to take on the very poisoned chalice of head of director of laboratories for the UK and the establishment of these and running of these laboratories. So, without much further ado, I'm going to ask Professor Damana if she would give us her keynote lecture on real-world implementation of precision medicine.
Thank you, Iain. Right, so thank you very much, Iain. This sort of introductions are very dangerous because from then on it's downhill all the way, yeah? As you know, and I was on BA very, very late flight, so I haven't checked the slides. I hope they're working. Right, I hear you've had fantastic meeting. I have seen the program. I'm sorry I couldn't hear this fantastic debate here. It sounded really great. But I would like to talk about precision medicine in a broadest sense. I know that my colleagues from Cambridge Press, from Prism Journals were here earlier, and I hope you talk to them because we're changing the world. We're changing the definition of precision medicine. We're bringing everybody together, and I hope all colleagues at this meeting and many others will join what I think is a revolution in medicine. So, what I would like to discuss with you briefly, and I know you've had a long day, so I'll be brief, is the precision medicine or precision healthcare. The name doesn't really matter. You'll see, provided we all work together, I think, because it's a collaborative team venture. I think we'll talk a little about are we ready to adopt all these great ideas into real healthcare delivery. We talk a little about it actually saves money to do things better. There are lots of people who don't believe that that's the case, but I'll show you some evidence. We will talk about living laboratory, which is the Glasgow concept at Queen Elizabeth University Hospital that Iain mentioned, the large grant in the middle of Govan trying to change not only what we do in hospital, but also what we do in community. And I'll mention a little what's happening elsewhere, namely in the US, because we always need to look across Atlantic a little bit, and then give some examples of the legacy of COVID. Clearly, diagnostics, as Iain mentioned, had really important role during COVID. It wasn't easy, but we created this large factory-like laboratories. We need to use it now for other things, but it's not straightforward, as you can imagine. So this is the Queen Elizabeth University Hospital that Iain mentioned. And from the beginning, it was always designed as this triple helix partnership on research issues with university in the lead, but working very, very closely in tandem or triple helix, as we like to call it, with NHS and industry, and not only life sciences industry, everything else. I heard you discussed AI, absolutely small digital companies that do AI, machine learning. All this I see under this little industry heading. Now, the precision medicine or precision healthcare, as Americans started calling it. And you know that there are, of course, other names, personalized medicine, stratified medicine, as Medical Research Council UK used to call it, but it all means the same. And it probably doesn't matter what we're calling it, because if in a few years that will be just medicine, I would like to make a bet with you. But the idea is that you have an affected population, you have tools, including ancient tools like examining the patient that some of the colleagues occasionally forget, particularly on this other side of Atlantic, never here, never in the Royal College of Physicians and Surgeons of Glasgow or any Royal College in the UK. You see here your stuff, genetics, genomics, molecular tests, but also imaging, hugely important and sometimes forgotten in these discussions, and looking at therapeutic response. But what happens is that one disease stops being one disease, that nomenclature needs to change, that we need to reclassify disorders, and you've been part of this. And we have this strata that's very, very visible in cancer. As you know, cancer has been at the forefront of precision medicine, but cardiovascular disease, cardiac conditions that you are interested in are equally in there, maybe not always aware that that's what we're doing. The value is that we diagnose better, we are earlier at diagnosis, we're treating before symptoms appear frequently, and therefore prognosis is better and response to treatment, of course. But never forget that in all these processes, we find new leads and potentially new druggable targets, because in this very detailed molecular diagnostics, there are new pathways discovered that lead to new treatments. So it's much more than just diagnosis and right treatment for right patient at the right time. This is simplification, and that's why we will publish a different, I hope, global, bigger definition of precision medicine. But what's at the bottom there is really important. You can't do it alone. Ivory Tower somewhere there in Oxbridge cannot do it alone. And neither any ivory tower. That needs to be a collaboration of the academia, health service, and industry. And it only works in this triple helix collaborations. And of course, patients, hugely important, patients and communities, because it also applies to health, not necessarily disease. Now, is it ready for clinical adoptions? Well, I've always been an optimist, and I think it is. We may argue it if there is time for a bit of discussion. I think we have learned, in addition to genomics, that obviously is the most important, all this other omics. We know how to integrate this. We can model functional annotation of symptoms, diseases, phenomics. We understand that flow of biological information, and I think we are ready in many parts of medicine to adopt clinically. And I'll try to persuade you that this is the case as we go along. But we do need an ecosystem. Precision medicine ecosystem is really the key. And this is now old paper from 2015 from Nature. These were two genomics experts. I modified it in two ways. I added imaging that they forgot about. I think we cannot forget imaging. And I also added other omics. Yes, genomics is enormously important, but there are other ways to look at molecular mechanisms. And you've seen them on the previous slide. So this is great. Electronic health records were Scotland and UK probably better than other countries, of course, because we mostly have National Health Service, so it is easier. It's not perfect, but at least we do not have, like Americans, Blue Shield, Blue Cross here, another huge company that doesn't release or share data. But what I think is the most difficult is at the bottom, this knowledge sharing. It's not enough to have one ecosystem. All ecosystems for precision medicine need to connect both within the country and internationally. It needs to be a global collaboration. And the journal, Precision Medicine, that is about to be launched in January, will try to make it global, to bring interested parties all over the world together. Now, in the west of Scotland, and I'm sure you heard about it, and I borrowed one slide from these three wonderful ladies, Caroline, Ruth, and Rachel. As early as 2008, a service has been established, and that's precisely part of such a collaboration between NHS, academia, and others, and families and patients, to provide an ecosystem that helps patients and helps their surrounding to get things right. And I think this is a great example how this could be done and connected. And your very meeting connects at least the UK, but we probably need more. Now, I said that there is evidence, increasing evidence, that doing things precisely is actually cheaper than doing things not so precisely. I know this is sort of risky. Oops, it stopped moving for some reason. I'll try to do. Right, okay, I think it needs more pressure applied. So just before COVID, in early 19, we worked with BASE in London, Department for Business, Energy and Industrial Strategy, and published one of the science audits. These were invited across all disciplines, including engineering and other, and this was basically to look at variety of potential innovations and how these could be applied across the UK. And we have published Precision Medicine Innovation in Scotland. This is available on the website, has been quoted and cited by many, and allowed us to fund. It really doesn't want to move. Is there some way to do it better? Right. Don't know what I'm doing wrong. Right. So it showed that the global market value in 2016, this is better? Okay. The global market value in 2016 of precision medicine, as we see it, was 43 billion. And 2025 prediction was that it will go up to 134. This is in US dollars, as you might imagine. We also did, with our health economists, the analysis that applied to Scotland alone. And had we been able to adopt precision medicine in major disease groups, so cancer, infection and immunity, cardiovascular and metabolic, etc., these would have been savings for the NHS from healthcare cost avoidance, and I'll show you how this is calculated in a wee minute. We also talked to industry partners. Remember I said that precision medicine cannot be really done without industry, and there are many reasons for this. And this was an independent survey by independent company that contacted many Scottish companies that believed that they practice within precision medicine area. And the biggest priority for all of them was to adopt it into NHS, which is really interesting. And you will see this echo in American and other publications quite a lot. There are other things that they wanted us to do, but this was by far the most important for these partners. Now, as it happened, Scottish Enterprise repeated some of these analyses now in 2022. And the global market value had gone even higher than people expected. We're looking at more than $200 billion by 2027. They also found out in that analysis, recent analysis, that there are 100 firms, 100 industry organizations across Scotland that do precision medicine in some shape or form. And 25 of those, that is 1/4, work with Precision Medicine Scotland Innovation Centre, funded by Scottish Funding Council, Innovation Centre at Queen Elizabeth University Hospital. They also looked at an important international database of companies and again found that there was a number of companies and a lot of employment for Scotland in precision medicine. But we're also very aware that there are companies, big and small, operating in this area, but not aware that's what they do. So these numbers are probably less than reality. So there is a lot that Scotland, UK can do in this particular area. Now, this is an American publication from 2021. Ginsburg from Duke's has been publishing quite a bit in this area. This was really a workshop that looked at this sort of US round table, published as a discussion paper, what is the plan for US for 2021 and beyond. And you see that the same areas come to light. Adoption is hugely important. There is no point publishing in Nature or New England and not adopting for patients and population. So that was really important. Other important things that our journal is going to address also is equity. It's very, very easy, as we know, in these areas where there is big innovation and improvement, to serve populations who normally are better served by medicine and not do the opposite. And it's very, very important that precision medicine doesn't cause further divide into those who have and those who do not. Clearly, it's terribly important to talk to politicians. That's why I have taken this very, very busy role on the 1st of July. You need to push these things because otherwise they don't happen. And of course, innovation and adoption of innovation is key to progress. And there is a plan in Scotland to adopt innovation at scale once for Scotland, despite the difficulties we're currently facing in our NHS. So this is the Living Laboratory for Precision Medicine. It is a huge grant from UKRI, one of those Strengths in Places fund. So this is meant to equalize. It is meant to level up, not only in health, but also economically across the UK. So 38 million from UKRI, matched by industrial partners and the city, to overall program of nearly 90 million, probably one of the biggest grants we've ever seen in biomedicine in Glasgow. You see number of industrial partners, and you see the aims. Accelerate productivity growth. This is truly measuring economic growth. Support NHS, of course, through this healthcare cost avoidance, and I'll show you one very significant example. But most importantly for all of us, we are clinicians to improve patient outcomes. There is no point doing all these other things if patients do not have benefit from it. These are some use cases. I'll describe very quickly a few of them, just to show you what's going on at the moment. Perhaps the most interesting is the pharmacogenomics, where that healthcare cost avoidance is very, very clear and very easy to calculate and see, even from preliminary data. There are others that I'll go through very quickly with you. So pharmacogenomics, you're familiar with. We prescribe, people get adverse reactions. Many of those are avoidable by a simple genetic test or set of tests, SNPs, on a chip. You don't need whole genome, you don't need to spend huge amounts of money, and yet we don't do it very often, even where it's obviously indicated. So clearly, I don't need to explain to this very highly educated audience that polypharmacy is everywhere, particularly in the elderly, and polypharmacy ends with a lot of adverse drug events. As shown here, 11% of unplanned hospital admissions, and 70% of this are elderly on multiple medicines, and you know that usual 10, 12, heart failure, and everything else. So there is also strong correlation between very big, very bad polypharmacy, that is 10 plus medicines, and deprivation and multimorbidity. So these things correlate when you look at them carefully, and it happens earlier in younger people than we would normally predict. There are some data from Scotland shown here that in 65-year-olds or more, patients would be on at least 5 different drugs, and they would have adverse drug reactions, of which 50% have been described as preventable. So this is what's been done. This is preliminary study before the grant was awarded. In silico study, looking at data from Greater Glasgow and Clyde Health Board, so one Scottish health board, the biggest, but just one, so you can extrapolate this to the whole of Scotland. So we looked at 65 plus people on polypharmacy. They were on 8 drugs on average, so you can imagine how bad it could go. Most prevalent condition, Iain, was high blood pressure. It's always been. However, the most costly one was diabetes. Again, nothing surprising here. If you look at this cohort, 165,000, 36,000 of them were at risk of genetically predictable or measurable or testable adverse drug reaction. So that's a lot. But looking at it from the point of view of this health care cost avoidance, it's been calculated by our health economists working with the company Thermo Fisher Scientific that the potential savings would be £85 million. This is now in pounds, in 3 years. If you extrapolate to 5.5 million Scots, you can quickly calculate that doing things well and serving patients well, you also save money for the NHS in such important way. Now, the second smaller but equally important project was so-called STAR, great name, Scottish Transcriptomes Archive Resource. So 30,000 transcriptomes from our pool of tissues in Greater Glasgow and Clyde Health Board. Every surgery, biopsy, etc., means tissue that would be available for research, and patients could say no, but very seldom do. So this is on an opt-out basis. We have very good, well-working biorepository, and this is how this program was generated. And the idea is that these tissues that are annotated, anonymized, but very well annotated with clinical data, could then be used for drug discovery, for looking at things in novel way, looking at novel pathways in multiplicity of diseases by multiplicity of collaborations between academia, health service, and industry. And then imaging. I mentioned imaging. We happened to attract a company from Germany, so that's inward investment. I should have said, I forgot, the company that did 30,000 screens on a previous slide moved to Scotland from sunny California. That's a real inward investment, yes? You come from the sun to the rain because you have something really special in our health service and in ability to access tissue, to work with clinicians easily, to collaborate. And that's why that small medium enterprise relocated to Scotland. This even smaller company that specializes in making coils for MRI in very advanced and specialized way moved from Germany to Glasgow because we bought 7 Tesla MRI, put it on clinical site that was first ever in the UK, 7 Tesla on clinical site with patients along the corridor, patients with neuro conditions. And these coils show pictures of the brain we've never seen before, incredible. You see some of this here. So, for example, the visualization of posterior fossa here of the cerebellum is incredible. And you also see small vessels in the brain, maybe not so much in this particular pictures, but we've seen vessels we've never seen before because they're so small, but 7 Tesla with this coil that enhances the image shows this. And really interestingly, Siemens is the main customer for this small company because Siemens, despite their greatness and international presence, cannot do it as well as this small engineering company that relocated to Glasgow. So that's your inward investment par excellence. And last but not least, there are these companies that do digital health, that do AI and machine learning at scale, that come with algorithms that could perhaps change the way we practice medicine. And this could be 2 young computer scientists. But in order to do things in health, which is very difficult for them, they need help. They need to be surrounded by clinician scientists. They need to understand how to access clinical data safely. And that's what Digital Health Validation Laboratory does. It provides a test bed for these small startups to be closer to clinicians, to understand how to go from discovery to adoption, to understand very complex ethics and regulation in health. For them, it's much easier to go to fintech. The same technologies apply to go to tech companies. We want to bring them to health, and that's what we're trying to attract them. So that was a very quick sort of run through what's happening in the Living Laboratory. Here are some comments from various stakeholders and visitors. I won't read it all to you. We're very proud of some of those. I'll just mention one on the top left. The potential to become the Silicon Valley of precision medicine, said Professor Victor Zhao, known to some cardiovascular people, who is currently the I think it's director or chair of U.S. Academy of Medicine in Washington, and previously advised President Obama on precision medicine when Obama was in the White House. So clearly, something good is happening there. More can be done. I would like it to be happening faster and better. It's not easy, and clearly COVID delayed progress there because the grant was awarded weeks before the pandemic started. But the pandemic taught us a lot in diagnostic world, I believe. This is the Rosalind Franklin Laboratory, which is in the Leamington Spa, the Royal Leamington Spa. This particular location has been chosen because it's in the very middle of England and 2 hours from all major UK airports. And this laboratory is like a factory. It's enormous. It has 10 lines of separate laboratory activity, some for, of course, PCR and COVID as it was designed, some for sequencing and genomic work. And the question is, should we maintain these laboratories that have been built during the pandemic for 2 reasons. First, for pandemic or other emergencies preparedness. I'm sure you're aware that a number of groups, including a group in Scottish Government, we are working to advise governments how we should be prepared. The difficulty is that it costs money to be prepared, and money is not in large supply at the moment anywhere. But the second thing is that having established these huge diagnostic facilities, could we use it in the interim for something else? Could we do diagnostic differently? We have trained certainly entire UK general population to do a test at home, send it somewhere, and expect a result in 24 hours on your phone. Why not do similar things cheaply, efficiently, well for other conditions? That's a question to you. Clearly, the team there that is working, this was built in 9 months, the laboratory that normally would have taken 5 years to build. It is a fabulous molecular laboratory. Whether it's going to be continuously used outside the infectious diseases and pandemic, it's still being worked on. So, in summary, we have developed high-throughput diagnostics. We can do it. We can only do it collaborating with life sciences industry. That's what happened during COVID. All the barriers, all the conflict of interest, worries and everything just disappeared in 1 week, just disappeared overnight. And everybody worked together, and things that normally take a year have been done in 2 weeks. Can we continue that way? We have developed consumer-centric primary care, definitely. This digital high street first. Can we carry on with this? We have done a lot of mass screening. Perhaps it wasn't preventative, but could we use it that way in the future? Are you believers in polygenic risk scores? Some people are. Would it be interesting to do it at larger scale? And definitely we do need to detect disease earlier. Cancer, no doubts, other conditions also. And this personalized treatments interventions, so precision prevention, precision medicine, is really a natural follow-up from all these things that have been developed. I believe that medicine never goes backwards, that patients will tell us that they want this sort of medicine being delivered to them. And you have seen, I hope, in the breaks, the journal. We launching January. It will be international journal for precision medicine. We have large international editorial board, not shown here, up to 40 people. They from all over the globe. And also we have colleagues from industry, colleagues who look at ethics of it all, and other areas. So very, very broad look at precision medicine. Thank you, and I hope we'll have, I know it's late, but I hope we'll have some time for a few questions, because this is really for a debate. I've been on purpose a little pushy here.
Thank you very much indeed. There's one thing that really interested me in your talk was the ability to give young groups a startup. My own son is in Boston and MIT, and they have projects in data analysis. And if you give them free data, it's quite extraordinary what these young minds can come up with. So is that, how freely available will data be to people?
Yeah, so this is a really important question, and there is a lot of discussion and debate in the NHS and in Scottish Government currently to make it as open as humanely possible. There are, of course, worries in general population. You know that in England there were a few unfortunate events with Google, DeepMind, etc., where patients and population felt that the data were being sold. So one has to be very, very careful. In Scotland, there has been a lot of trust in medics generally, and patients, communities want to share data, but it needs to be done in such a way that the benefit of the population is very, very clear. So at the moment, I think it needs to be collaborative. So a small startup, as you're referring to, and there are many, particularly in Lothian, we need to do better in the West, but in the East, there are lots of these small startups, and they collaborate with either university or NHS trust and get access to data to do this work. And I think there will be more of it. The data strategy is being produced currently by Health in Scottish Government, and this, in fact, tomorrow we're presenting to colleagues how we would see in health that the data could be shared with industry in a way that doesn't in any way take away privacy, that it's anonymized right correctly, and there is benefit for industry, but there must be benefit to our population at the same time.
Do we have hopefully time for a couple of questions?
They're exhausted.
Okay, right. It's really exciting.
Thank you.
Thank you very much indeed, Anne.
Thank you.
So thank you so much. Thank you, everyone, for staying for quite a long day, and but I hope it was rewarding. I thought it was a fantastic program, Caroline, and brilliantly executed by all the speakers. I just also like to add my thanks to our keynote speaker. What a job you have championing all that with politicians and industry in this economic climate that we're in. Well done. And thank you from all of us for your work and endeavours. I'm sure it's very time consuming. So I just need to present the abstract prizes. We have, and these come with a cheque for £100, which I don't have on me, but we will be sending to you, and a complimentary article processing for precision medicine. So we have the top scoring abstract non-medical
which goes to Catherine Moore from Leeds. Catherine, I don't know if you want to come and collect. She put together a fantastic piece of work on patient survey of virtual appointments during COVID, and looking at what patients would prefer, which was a fascinating piece of work of where we should take this going forward. So well done, Catherine. So the second abstract I have, which was the top scoring abstract from a medical perspective, goes to Joe Westaby, who's featured a lot on the stage today, on his abstract looking at obesity cardiomyopathy, and has put us all off our food for the and finally to the clinical case award winner, and that goes to Will Young for that fantastic presentation about that really challenging case that they dealt with at Barts, and highlighting the role of psychology and those needs for patients and families. Well done. Will would like to sing now, I think. Thank you very much, everyone. A few more thank yous. This excellent programme was really led by Caroline. Caroline, it's been fantastic. I thought she had just volunteered. It was the night we were in the pub after the last conference, and I wasn't quite sure, but I think you had given it a bit more thought. So we'd just like to give you some a small token of and your co-workers, Rachel and Ruth, thank you very much for all your help. I think we also have to acknowledge Eleanor Wicks, who sadly can't be with us, but she's at home and she's sent me so many texts. She's still keeping us on track with what's going on and dealing with the enormous amount of changes that had to happen in the last sort of 48 hours. Other years we were hit by COVID, but this year we suddenly realised we were going to be beleaguered by the train strikes and the threat of those, and then of course the weather. So well done to all of you who've had the journeys from hell and back. Well done for making it. So Eleanor has kept us on course, and I'd like to say a big thank you to her. And also to Gillian, who from NICS, who was a huge administrative help to us, and Valerie Honore from the BCS, who've been fantastic in helping us, getting us over the line. So thank you very much, everybody. I hope many of you will be joining us tomorrow at the National Training Day at the Golden Jubilee Hospital. Do you want to come and say something about that, Ruth? Oh, right, yes. As announced earlier, Ruth is the champion of organising a night out, so she's going to tell us what's going on with the dinner. There have been a whole number of changes because, sadly, I think about 9 people who were booked in for the dinner tonight, of course, have not made it. But there are a few others of you who want to join us, so we're delighted.
Just to provide an update about that. So I hope, after Joe's talk, we haven't been put off for food too much, because this is a lovely Italian restaurant and it's called Santa Lucia. The link is, I think, in the information that have been sent, but if you've got any queries about where to go, then you can just either follow us or ask Gillian at the front door. There's been a few people that obviously had paid and aren't able to attend, but I think there's equal numbers of people here who have not paid but wish to attend. Anyway, so if you've not paid, or if you're not sure whether you've paid, then if you can speak to Gillian at the front door. If you paid, then you paid via a PayPal link, and you will have received an electronic ticket, if you like, for the meal. But if you're not sure if you got that electronic ticket, then you can check with Gillian, because she has a list. That's all.